moving on to our next session, session 2, which is on overview of pain management, I would like to call Dr. Nimisha Verma, Associate Professor, Department of Anesthesia and Pain Management at IMS BHU, to enlighten us with her talk. Welcome, Dr. Nimisha. I would now request the chairpersons for this session to kindly grace the stage. Our first chairperson of this session is a very renowned orthopedic surgeon of Prayagraj, Dr. K.D. Tripathi, sir. Our second chairperson is Dr. Rajiv Gautam, Professor and Head, Department of Anesthesia, Azamgarh. And our third chairperson is Abhilasha Chaturvedi, ma'am, who is a senior gynecologist and infertility specialist in Prayagraj.
Thank you, ma'am. I think the pain is one of the most oldest and very common presenting symptom in all clinics and all hospitals. Let it be OB-GYN. I think in the OB-GYN it is one of the most productive pain. Most severe, most productive pain. Otherwise, all the pains like myocardial infarction in the cardiology, colic pain in the surgery, abdominal pains, the carcinogenic pains, the pains of trauma, they all present. I think it is one of the most common presenting symptom in each and every clinic. Yeah. Dr. Nimisha is going to give the overview of all these pains. It is very important topic for all of us. And Dr. Abhilasha is going to introduce our speaker.
So, Dr. Nimisha is the alumnus of this college. She is, at present, she is in BHU, Associate Professor, Department of Anesthesia. Education, already MBBS from Allahabad, MD Anesthesia from Kanpur, GSVM Medical College, and PDCC Pain Management is from BHU. She has done many publications, 6 national, 13 international. She has written 3 books also. Her chief area of interest is chronic and cancer pain management, palliative care, and onco anesthesia.
So why do we talk about pain here in a conference which is addressing more of neurology and hematology? Is because about 2 million people of the 8 billion, 2 billion people of the 8 billion population of the world suffers from chronic pain. And this leads to significant disability amongst the sufferers, and it leads to massive healthcare costs and work absenteeism. So to address this issue, I am going to share with you the recent definition of pain, the recent developments in the types of pain that we have. This is more of theory, but to understand the pain properly, we have to know this. And then how do we diagnose a case of chronic pain? And with emphasis on chronic low back pain and interventional pain management on chronic low back pain, knee pain, and how do we approach labor analgesia as well. So there is a body called International Association for Study of Pain, and they, from time to time, they have been revising the definition of pain. And it is recently, into 2020, they have redefined pain as an unpleasant sensory and emotional experience associated with or resembling that associated with something like actual or potential tissue damage. The definition is emphasizing the importance of the sensory as well as its combination with the emotional component in identifying the intensity of pain in individuals. And this definition has been expanded by 6 keynotes, like pain is always a personal experience. It is a combination of the biology, the psychology, as well as the social aspect of an individual. Pain and nociception are different phenomena, and they should be considered different as well. And we learn our experience of pain throughout our life. Our past experiences, our emotion, all guide the perception of our pain. And also, although pain is protective, it has some adverse effects, and verbal description of pain is only one of the ways in which an individual expresses his pain. So to unconvolute the complicated definition, we can broadly classify pain into two types. One is the adaptive pain, which is acute in nature, and it is protective in nature. Like when we put our hand in fire, we reflexively take it back, and this goes and saves in our memory that next time when we see the fire, we're not going to put our hand inside it. And on the other hand, there is another pain, which is maladaptive pain, which does not protect us from any harm. Our body is not protected by in any way, and this pain is because of the malfiring of the neural circuits or central sensitization in our brains, which is in easy words we can call as rewiring of our brain, and this entity is known as chronic pain. Any duration, any pain which is present with us for more than 3 months can be labeled as chronic pain. To understand and to diagnose and as well as to treat pain, we should be well aware of the mechanism of pain. And in the recent times, in 2021, a new Nobel Prize has been given for the new pain type, which is nociplastic pain. And so, coming back to the mechanism of pain, there can be 3 types. One is the inflammatory pain, which is acute in onset. Sensory and peripheral and central nervous systems are involved, and it is the kind of pain that we see in a laboring woman or when we have a cut. In contrast, there is another kind of pain which is known as neuropathic pain, which is due damage to the somatosensory system, and there we have the peripheral and central nervous system involvement, and this kind of pain is experienced when we have a sciatic pain, or we have like diabetic neuropathy, or a carpal tunnel syndrome, or a pain after herpes zoster, post-herpetic neuralgia. And then a new type of pain has been discovered in which there is no inflammation, there is no lesion to the nerve, but still the individual has pain. This kind of pain has been designated as the disease of the central nervous system, and it is seen in patients with fibromyalgia. So the treatment of these inflammatory pain is NSAIDs, neuropathic pain is blocks and antipsychotics, and central sensitization again is some levels of stimulation, some peripheral, central stimulation and all. So we can see that the management of pain will change according to the mechanism of the pain. And we can have a combination of all the 3 pains together as well. So easing it further, we can have pain as somatic, visceral, neuropathic, and central, and all the components can occur together as well. And pain is always going from the periphery to the center in 4 steps. Like one is transduction, when the nociceptors perceive the pain, convert the signals into an electrical stimuli that goes from our dorsal horn neurons into the spinal cord, and then up through the spinothalamic tract into the ventro-posterior medulla, and then to the somatosensory cortex. So wherever we get the pain, it is always perceived in the somatosensory cortex. Thanks. Coming to the diagnosis of pain, if we fail to assess the pain, we fail to diagnose the pain. So it will be helped by proper history taking, by evaluating evaluating pain with the help of pain scales, by proper examination, neurological, general, local, as well as musculoskeletal, and by ordering specific tests and investigations, blood as well as radiological. Coming to the multidimensional pain scales and unidimensional pain scales, we know that pain cannot be objectified. It is a subjective experience. So for the physician to understand how to assess the pain, a certain pain scales have been devised, and they are either multidimensional, which address all aspects of pain, or they are unidimensional, which address only the intensity of the pain. And these are The most commonly used among these are the numeric rating scale, which is a 10 centimeter line, in which 0 represents no pain and 10 represents worst imaginable pain. And we ask the patient, where do you think your pain lies? And in this, the drug treatment goes according to the mild, moderate, and severe pain scale. So for mild pain, we'll give an paracetamol or an NSAID. For moderate pain, we go on to getting tramadol. And for severe pain, we may go on to give a combination of adjuvant drugs, NSAIDs, plus morphine or opioids, whatever is applicable. Then there is another scale called verbal pain intensity scale, which divides pain into mild, moderate, severe, very severe, and worst. Then there is a combination of all the scales. This is the total pain scale, which is a horizontal line which shows, asks the patient where the pain lies on this scale. And these scales are very important to help in further follow-up of the patient. If the patient has a score of, say, 6 or 7 or 8, and if after in the follow-up the patient has a score of 3, we are sure that we are managing the pain in the correct lines. So this, the last is the Wong-Baker pain scale, in which there are different phases. This is for uneducated people or children where they don't understand the numbers, so they can see the face and tell how much it hurts. Coming on to the management of pain, it will always be a combination, a multimodal management will be required, and it will be a combination of non-pharmacological, pharmacological, and interventional pain management. And in the subsequent talk, I will be focusing only on the percutaneous interventions that we do, and they are known as minimally invasive pain spine interventions. They are generally done using image guidance by fluoro or by ultrasound. One thing which we have to keep in mind always is we have to balance the risks against the benefits. Coming on to the causes of low back pain, the lower back has got multiple structures which are pain sensitive. Not all structures are sensitive and not all structures are insensitive. And amongst the sensitive structures, the anterior posterior longitudinal ligaments, the ligamentum flava, the supraspinatus ligaments are all very painful. They respond to painful stimuli. The facet joints, also known as the zygapophyseal joint, is another pain generator. And then there is the vertebral body and the intervertebral discs. The common pathologies of lower back pain are disc pathologies. The ligaments associated with the spine stretch and sprain in them. The facet arthropathy, myofascial pains, vertebral compressions in the form of fractures, or sacroiliac joint sprain or iliitis or inflammation. For interventions, we divide the spine into two parts, posterior compartment and anterior compartment, and these two compartments are addressed differently and so mentioned. Before starting any treatment of pain, we have to rule out the red flags that can be seen in such patients, and such patients we have to do urgent radiological evaluation and go further for surgery. And these red flags are fever, neurological deficits, bladder bowel involvement, unexplained weight loss, swelling over the back, and constant progressive non-mechanical pain, as well as if this kind of pain exists in extremes of age, then also it should raise a mark and we should send the patient for further investigation. This is so important that it is easy to remember this mnemonic tuna fish to remember the red flags for evaluation of low back pain. T is for trauma, U is for unexplained weight loss, N for neurological symptoms, A for age more than 50, F fever, I for intravenous drug abuse, and S for steroid use, and H is for history of cancer like prostate, renal, breast, or lung. Coming to the armamentarium, what treatment options the MIPSI offers in low back pain are the epidural steroids, trigger point injections, plasma platelet-rich plasma therapy, radiofrequency ablation or modulation, cryoablation, endoscopic procedures, intrathecal drug delivery implants, and spinal cord stimulation. And the list is very long, but I have just mentioned a few which we practice commonly in our setup. And what I would like to bring home to you all at this point is that initially when the procedures started, they were neuroablative in nature. We used to burn the nerves by radiofrequency, and then we went on to neuromodulated. The same radiofrequency machine which used to deliver a burning current was used to give a lower dose of current so that there is heat generation and the nerve is not burned, but there is change in signals of the nerves. And then after that, now we are using platelet autologous PRP therapy and stem cell therapy, which is more like regenerative therapy rather than neuroablation or modulation. The figure here describes the Scotty dog, which is a very important structure for any intervention in the spine. So the different structures of the Scotty dog, if I may be able to show that this is the ear of the Scottish dog, it is formed by, this is the Scotty dog, if you can appreciate. The ear of the Scotty dog is formed by the superior articular facet. And this the cross behind the superior articular facet is the facet joint formed by the inferior articular facet of the vertebra above and superior articular facet of the vertebra below. The face is the pars, and this chin of the Scotty dog is the intervertebral foramen, which is from where the exiting nerve root comes out. And this is the lamina, and here is the spinous process. Next is the discogenic pain, which is one of the common causes of low back pain. Discogenic pain is more common on prolonged sitting and standing, and it gives an impression of a midline tenderness. It also leads to a band-like sensation, constricting band-like sensation in the back. The causes of discogenic pain are degenerated discs, annular tears, or chemical neuritis. In MRI, it shows a high-intensity zone. This is the HIZ. It is a whitish structure in the blackened disc. This is a degenerated disc. And provocative discography is the diagnostic thing that we use to diagnose the disc which causes pain. So evidence for interventional pain management for discogenic pain are intradiscal. Steroids can be given intradiscally. Radiofrequency treatment of the disc can be used in multiple ways. And we can do an intradiscal electrothermal therapy, in which a long electrode is put into the disc and heat is given, which causes neuromodulation. Or we can put two needles into the pain-causing intervertebral disc and burn it, which is known as biochiloplasty. Or a distrode, again, there is a long electrode which is put, the brand is different. And then we have the radiofrequency ablation of the nerves supplying the disc, which is the radiofrequency of Raymer's communicans. In a big way, autologous PRP has come, and I was fortunate to work on this project, and we have a few publications with autologous PRP disc in reputed international journals. Then for annular tears, which are this is the disc. The disc structure has nucleus pulposus and annulus fibrosus. This annulus is a pain-sensitive structure. So if there are tears, vertical tears or horizontal tears in the annulus, this nucleus pulposus, which is algogenic or inflammatory, leaks out and causes irritation it leaks out from here and causes irritation of the exiting nerve roots. This is the exiting nerve root, and this leads to either radicular pain or inflammatory discogenic pain. So in both the conditions, we do a biochiloplasty, IDET, or disc FX, which is an endoscopic procedure. Coming on to lumbar radiculopathy, it is again a very common cause of low back pain. The nerves The difference between discogenic pain and radiculopathy is that, okay, so lumbar radiculopathy, what we have to offer as pain physicians is transforaminal epidural steroid or endoscopic discectomy, foraminotomy, and piriformis muscle injection if it is outside the neuraxis. These are the evidence for management. Many things have got many slides. So facet joint pain is another very important cause of pain, and this facet joint pain comes when we axially load the patient and when the patient twists left or right. So it is a paramedian pain in contrast to the pain that is present on midline in the discogenic area. And only facet has class 1A evidence for interventions. Like for the facet joint, we do a medial branch block, and the evidence level of recommendation is 1. Coming on to sacroiliac joint, it is another pain generator in the back. It causes buttock pain, and which radiates up to the knee. And seronegative spondyloarthropathies, ankylosing spondylitis, sacroiliacitis, and SI dysfunction are to look for if the patient has got sacroiliac joint pain. These are the interventions possible. We can put a steroid in the joint, or we can do an RFA of the joint more commonly. And coming on to failed back surgery, if it is defined as a lumbar spinal pain of unknown origin, either persisting despite surgical intervention or appearing after surgical intervention. And the surgeons are helpless. So the pain interventionalist offers a very advanced technique of intervention, which is known as spinal cord stimulation, in which electrodes are put into the epidural space and they are stimulated so that it works on the gate theory. The patient is not able to feel the pain, but they have a different sensation that they feel in the back. Can be given by non-pharmacological methods like acupuncture, moxibustion, yoga and relaxation, massage, hypnosis, hydrotherapy, or Lamaze's method, in which special breathing techniques are taught to the parturient. And immersive VR is coming in a big way to help the laboring ladies to get distracted and not have the pain. Regional anesthesia is the gold standard, in which epidural itself is the gold standard for labor pain. Coming to my take-home message, knowledge of pain and its management is the must for all, because it is the 5th vital sign after heart rate, respiratory rate, BP, and temperature. Pain is always perceived in the brain, so irrespective of the site of injury, and undergoes modulation during its transduction, transmission, and perception. Proper assessment of pain is essential to treat it. Interventional pain management is an important tool in multimodal management of pain, and evolution of interventional pain is from neuroablation to modulation to regeneration. And thank you for your patience.
Thank you, Dr. Nimisha, for a very comprehensive lecture on the pain management. Lecture is open for the question from the house. Can we ask that many of us are sitting here, the operating surgeons.
Yes, sir.
In the Allahabad, I don't know in the BHU, but in Allahabad, I think we short of anesthetists. And as soon as the surgery finishes, our anesthetist is busy for another surgery. So yes, most of these patients we have to manage post-operatively. Elderly patient in the post-operative management, can you give some overview?
Sir, I did not...
For a surgeon to manage the pain management.
Asking about post-operative and
post-operative management.
So there is a whole protocol for the management of post-operative pain, and we have a post-operative acute pain management system is present. If it is in place, then it is very good. Otherwise,
the purpose of my question is the practical aspect of or busy nursing home. Not if they're not having an ICU, then how to manage these patients? practical management for the practicing doctors.
So what kind of post-operative pain is specifically and to management? Because if it is a neurosurgery, then it is different. Abdominal surgery is different. It will always depend upon the intensity of pain and the site of surgery, sir. If possible, then oral and IV analgesics are always available. You are very well aware of that. Apart from that, patient-controlled epidural analgesia. Epidural analgesia itself is a good choice in the post-operative period. Regional nerve blocks are good. And IV PCA is a viable option for post-operative pain management.
Yes, multimodal approach to acute pain management is the holistic approach, I think, using of the currently available analgesics, NSAIDs, adding with the occasional use of paracetamol, intravenous paracetamol, and currently some form of patches are available that can also be used at least for 24 to 48 hours.
Yes, sir, but the patches are not recommended for post-operative use, one thing. And second thing, the management of post-operative pain is ideally done in the pre-operative period, when the anesthetist comes for a PSC. So that may be a different working scenario, because I work in an institution and I reinforce this, that we have to see the patient before. Pain is something which is not one size fits all. We have to change according to what the patient's comorbidities
are. Definitely. And use of regional anesthesia types, yes. If it is infraumbilical or it can be epidural analgesia can be used for post-operative
yes, indeed.
period.
Epidural can be used for with patient-controlled mode or without patient-controlled mode, both. If we have a pump, which are very easily available now, that is LV5 pump, the patient can control the drug dose that can be delivered. We can give either bupivacaine or ropivacaine or fentanyl into the pump. And the same pump can also be used for IV PCA. In the intravenous line, we can connect it with fentanyl, not local anesthetics, with an IV fentanyl. If it is available, then it can be easily used. And this is all for the intensity of the pain, which is more than 7 or 8. For moderate intensity, tramadol is good enough in the tramadol and a combination of tramadol.
Fentanyl patches after OB and gynae surgery are quite popular.
Yes, ma'am, they are popular, but I have not come across any guidelines, any recommendations which say the patches were developed, specifically patches like buprenorphine and fentanyl patches were developed for the patients of cancer, and specifically chronic cancer, who were not able to take things orally, who had a lot of diarrhea or who had constipation, in which the oral intake of drugs was not possible. So if we are using it, we can use it, but the recommendation is not there.
Actually, the labor pain is considered the worst pain, yes. But the non-availability of anesthetist is a practical issue. So we can't use epidural anesthesia, yes, as it is recommended.
Yes, ma'am.
Because of non-availability of the specialist.
Yes, ma'am. Indeed, agreed and accepted that the anesthetist is not available, even in institutional setups, and what to talk about private. But counseling before the lady goes into labor will also help.
Apart from availability, I think the patient's level of the patient, of the surgeon, of the anesthetist, that is all needed, at least for labor analgesia.
What we surgeons do, we don't come in the night. In the morning when we come, patient के साथ रात में बहुत दर्द हुआ, हमने कहा रात गई बात गई, because we don't have any exact protocols, हम लोग रात में मिलते ही नहीं.
Yes, sir, that reminds me of exactly, sir. That reminds me of my orthopedic colleagues when we were discussing pain with him. Then he said there are 3 types of anesthesia. One is tocal, one is local, and other one is tocal, vocal, and local. So that is the vocal. Raat gayi, baat gayi. It's a good way of pain modulation.
But practically what we do was, first we give paracetamol, then we give diclofenac, then we give Temidol, then we give fortifenac. We just keep on giving all these kind of, because anesthetic is not available, epidural is not available, so just we keep on that and see in the elderly patient there is some problem.
So one thing from this lecture and discussion, if we can take home, is that if we ask the patient what is the intensity of pain, that will be very, very helpful for you and for me and for all of us to give the right analgesic. If the intensity of the pain is 0 to 3, yes.
दर्द जिसको होता है उसको होता है, उसको हम नंबर नहीं दे सकते कि 4 है कि 6 है कि 8 है. तकलीफ होती है, लेबर पेन होता है, पोस्ट ऑपरेटिव पेन होता है, एंड इट्स रियली सीवियर. और उसमें जो नर्स होती है, उसी का स्टाफ, नाइट स्टाफ होता है, वही झेलता है उसमें.
And one thing we can do apart from the college and institutes, that hospital should make their own protocols to management. That is the best way. Even the consultant is available or not available, and the protocol should be followed by a attending nurse or any trained person who is there.
Standard
That
SOPs.
is the standardization.
Ma'am, I run the pain OPD in IMS BHU, which is the most heavily infested pain OPD in the country, I think. And my experience of pain tells me that कोई आएगा chronic pain का patient, then we ask him कितना दर्द हो रहा है, बहुत दर्द हो रहा है, बहुत दर्द हो रहा है, इतना दर्द हो रहा है कि असहनीय है. But when we ask them to label it, then they say 4 and 5. So I have learned it that way, that if we ask the patient to quantify their pain, they are sometimes aware. They are saying too much of pain because they want our attention. Sometimes, or most of the times, the patient needs our attention, and this is one way to catch it. So if we tell them to give a number to their pain, or how much does it hurt, what is the meaning of that pain to that patient, वो चल ही नहीं पा रहा है, then we understand the intensity is high. But sometimes they are not able to understand, they do it only for attention.
Thank you, ma'am. It was a very wonderful discussion. I think we'll discuss later on the tea.
Thank you so much.
Thank you.